see.
Yeah. No, I'm happy to help.
That's amazing. Thank you very much. So this thing is just a few words, really, because I don't want to waste your time. The thing is that I started this channel about, I don't know, 6-7 months ago, because, we were sitting at home. We had the freaking quarantine here, and gyms were shut down. And as a PT, I couldn't work, from the gym. So I thought, well, I've got a lot of free time now. Let's try to educate people a little bit more. I've been doing this for 22 years, but I would say 80% of that time, I was really, really into bro science.
Yeah.
Yeah, of course, like technically everyone else from Europe. And when I moved here 10 years ago, I started studying. I mean, really studying, real education, real studies, and I realized that, well, first of all, I was wrong for a good 17 years. And the second, that everyone is wrong, really, in Hungary, because the thing is, real research, real science is just not available because it's all written in English. And, the company Cytec Nutrition?
Yeah.
I used to work for them, and they basically rule the whole Hungary. They are the biggest company, they have the biggest website, and everything they put out, that's the truth.
Yeah.
Of course. And basically they, Cytec Nutrition as a company, they consider to be the source of the information. And because we're talking about the supplement company, obviously they never going to tell you the 100% correct truth, because although they are, although they have the best intention to educate people, but of course the marketing and the money is still behind that. So I think that's one of the biggest reasons. And the other is people honestly think that the better you look, the more you know. Ask anyone, that's what they're going to say. The bigger you are, the more you know. And that's not the case again. And when I moved here, I started thinking about getting a qualification, a UK qualification. And that's how I got to know Simon. I finished a few courses with him, and he opened my eyes, basically. So I got into research more and more. And of course, I started following the right people rather than pro bodybuilders. I started following Roderick Chavez, Lane Norton, Mikey Strata. So people who really know stuff, rather than just pro bodybuilders. And that's the whole purpose of the channel, because I think the real information is just basically not available in Hungary. So I thought, let's just create a channel and talk about this stuff to Hungarian people. And that's what I'm at right now. So I already done an international, I would say, an international podcast with Broderick. And with him, we covered basic nutrition, because obviously I start the channel from scratch. So we can't talk about PEDs before we talk about macros, because people still believe that, carbs makes you fat, fat makes you fat, and all that. You can gain fat in calorie deficit, all these crazy shit. I just see no point talking about PED when people don't know even how the carb works. But now that's covered. So that's all covered. And I thought we could actually do the next step with you and maybe talk, about PEDs and side effects and supplements a little bit more.
Yeah.
So what I thought for today is, first of all, how much time you have?
I've nothing. I've no meetings this morning, so we've got whatever, an hour and a half. You don't want to go on too long that you lose people, but I've got no time limit that I need to shoot off.
Yes. Yeah, correct. And I know that my questions will be really broad and it's not specific and it's hard to answer. And I know we could go on for probably days on one single question, but that's what I wanted to ask you, that if we could just, squeeze as many questions as we can into this 1 hour. So I know we're not going to be able to cover properly each topic, but maybe just a little bit, and so what I thought is we could start with PEDs a little bit without going into specific, and then we can cover supplements, because that's really important, and then we can cover some of the recovery aspect, and then maybe go into genetics. And I think that would do for today.
Yeah,
right?
Sounds good. Yeah, okay. Perfect.
But before we start, would you like to introduce yourself a little bit and just talk about yourself a bit? Tell us a bit more about your background. Tell us who you are and what's your education, what's your background.
Okay, so for anyone who doesn't know who I am, I'm Dr. Dean St. Mart. My background is in drug development and pharmacology, and I then went and done a PhD in synthetic organic chemistry. So I guess people have come to know who I am from my application of functional medicine to bodybuilding to try and educate the safer use of performance enhancing drugs. So I pretty much became known on the Trained by JP forum as one of the educators for Jordan Peters. And that was probably my first sort of mainstream exposure to getting some of my theories out surrounding how we can potentially not have to use, bro science, and actually understand that there is a level of real science application when it comes to bodybuilding and using performance enhancing drugs. So for me personally, seeing some of the things that was being advised on a lot of the bodybuilding forums online just didn't really make sense when we sat back and actually applied real life pharmacology. For example, dosing drugs on a milligram per kilogram level of, take X because you weigh X doesn't really make sense from a pharmacology perspective on how we understand how when we take drugs, how they interact in your body and how they leave your body then when they're metabolized. So I tried to make things as simple as possible for guys to understand that if we can understand the root cause of why you may get sick or develop disease when you're using performance enhancing drugs, well, by having that understanding of the root cause, what strategy can you put in place in order to offset that disease from happening? And that can be anywhere from cardiovascular disease to kidney damage and kidney disease, or even hepatic damage or damage in your liver. So by understanding what potentially performance enhancing drugs might do in the body, we can then understand the root cause and then put a strategy in place. So I started to educate guys that you don't necessarily have to follow, the gospel of what's being told to you online. If we understand why these drugs were developed in the first place and how we might take advantage of those drugs from a cosmetic and performance enhancing aspect, then we can do things a little more intelligently.
Right, cool. As I mentioned you before the video that I already had one show with Roderick Chavez, and actually he's really big on milligram per kilogram, the dosing. And with him, we could cover what's the difference between steroids and anabolic steroids. So that's pretty much clear to everyone at this point right now, I hope so. But with you, we could cover a bit more commonly used terms in bodybuilding. And if we could start with the first one, what is PCT? Because people always talk about PCT, but very few know actually what it is, how does it use, what's the purpose of that. So basically, if we could cover what is PCT and what it's used for.
Yeah, so PCT is post-cycle therapy. It's the phase following the use of performance-enhancing drugs where we allow the drugs to clear from the body and try and restore normal physiological function. So in males, you have your hypothalamic pituitary testicular axis, the HPTA, and that is the system that produces testosterone in a male's body. It starts off with the hypothalamus making a stimulating hormone known as gonadotropin releasing hormone, and that goes to the pituitary and stimulates branches of neurons to produce the two male fertility hormones, luteinizing hormone LH and follicle stimulating hormone FSH. Those two hormones then, once they leave the pituitary, go down to the testicle and stimulate two distinct types of cells. So we have the Leydig cells and we have the Sertoli cells. The Leydig cells are what create testosterone, so they perform steroidogenesis. LH stimulates the Leydig cells to produce testosterone from the Leydig cells, and FSH goes to the Sertoli cells and stimulates the maturation of germ sperm cells. So both have independent actions of one another, but are, I guess, intimately linked. So without testosterone production in the testicle, it would be very difficult to have any appreciable level of sperm being produced. So we do need a small amount of testosterone being made in the testicle to support sperm's maturation. So when we take exogenous steroids or exogenous hormones, that HPTA cycle gets shut down. So the brain senses that there's no longer a need to pulse these fertility hormones in order to maintain normal levels of hormones in your body. So by taking, say, for example, 250 milligrams of testosterone, you're yielding a blood level of testosterone of about 40 to 45 nanomolar. So that's, in most instances, say the average male produces anywhere from 8 to 30 nanomolar of testosterone. You're now outside that physiological range, and more than likely outside your own physiological range. And that has negative consequences then, because the hypothalamus senses this high level of testosterone. And because of injecting these ester forms of testosterone into the body, they have a slower rate of release. So the hypothalamus then senses that there's elevated levels of hormones continuously in the body, and therefore does not need to make any form of stimulating fertility hormones. How you approach PCT then is the most obvious way from a pharmacology perspective would be just allow the drug level to clear from the body. So if you administered a certain dose of testosterone and it yields a test level of 45 nanomolar, depending on how that ester is cleaved and leaves your body, you'd then obey the half-life of that molecule to assess how long you need to wait in order to determine, do you need to even implement any form of drug therapy to help your own testosterone production. So this was sort of where I became well known online, trying to get guys to see the sense that forums would be suggesting that you start PCT after 2 weeks, regardless of what you took. And it was just plain bonkers when you understood the drug therapies that was involved between HCG, which is human chorionic gonadotropin, and then following with a period of SERMS, which are selective estrogen receptor modulators like Clomid, Clomiphene, and tamoxifen or Novadex. By understanding what these drugs do, you can then understand you actually even need to use them for a PCT. So by being patient and allowing the drug hormone level to fall, your HPTA is a delicate system that has evolved over thousands of years. So its job is to produce fertility hormone in order to make testosterone. So when you allow that hormone level that you've exogenously administered, your testosterone should, in theory, begin to be produced from your brain down to your testicle. In the instance that your brain doesn't respond to that fall in hormone level that you administered yourself, then you might need to do a PCT. So in that instance, you might need to use HCG, which is a synthetic form of luteinizing hormone. And we use that in order to stimulate the testicle to produce some testosterone. So by stimulating the testicle to make testosterone through the HCG, we now have a small amount of testosterone being able to circulate from the testicle into the blood, up to the brain, and stimulate the brain to make fertility hormones in order to get that cycle up and running faster. So if you administer HCG when you have a high level of testosterone because you started your PCT after 2 weeks, you're going to run into a scenario whereby the luteinizing hormone stimulation of the HCG does nothing. You're effectively administering something that has no effect on your testicle. And more often than not, if you do start after 2 weeks, the average half-life of testosterone enanthate, depending on a person's genetics, administration site, the carrier oil, all these things play into the elimination of these compounds. But if we take on average the half-life of testosterone enanthate as 4 to 7 days, so that's 4 to 7 days is what it takes for half that drug concentration to decrease. If we even take it to be 7 days, if we just want to err on the side of caution, the average rule within pharmacology is that after 5 half-lives, so 5 divisions, we should pretty much be at 99% clearance of a drug. So pretty much a total elimination of a compound following 5 half-lives. So if we take that general rule to testosterone enanthate, then we see that we have 5 weeks. So if the half-life is a week, 5 weeks before that drug has fully cleared from your body. If you begin HCG after 2 weeks following your use of testosterone enanthate, you're effectively putting HCG into a system that already has a high level of testosterone.
That's amazing. That's amazing. Sorry to interrupt, but you just covered about 6 more questions of mine with all this. That's what people does. First of all, I don't think that anyone knew that shutting down your testosterone production does not really depend on the dosage. So as you said, one single shot, 250 test can actually shut you down completely. And the other thing is, which I got every single day this question: when should I start my PCT? And people have been told that the day after your last injection, maybe a week after your last injection, which is completely wrong. But you just covered that. That's amazing. And the other thing is, do you always need the PCT? Because you just said that you have to let your level drop before you start that. But if you are planning to do another cycle within a month or 2 or 3, whatever, does it actually make sense to trying to make our body to start producing testosterone again? Because we're going to shut it down within 2 months again. So do you always need a PCT?
Yeah, so in my theory, and my sort of viewpoint on this is, if you're going to do another cycle of steroids within, say, 4 or 6 weeks of your cessation, then it makes 0 sense to do a PCT. A fully restorative PCT can take anywhere from 5 weeks, so you may get lucky, and when the drug's fully clear, your brain senses that drop in hormone and starts producing GnRH and the 2 fertility hormones. So in that instance, you wouldn't need a PCT. And that's why it's important that you get your blood work done for your male hormones when you let the drugs clear, to assess, do you need to do PCT? Do you need to put anything into your body? Because if you get your bloods done after 5 weeks of letting the drug clear, and you have a positive result for LH, FSH, and testosterone, by putting PCT drugs in, you may make things worse. And I've seen this countless times with guys' blood works where they've allowed the drug to clear, and by that point they've had bloods done where they actually probably didn't understand their blood work too well. Their LH and FSH was normal and their testosterone was normal, but because their coach told them they have to do PCT, they went and started taking HCG and Clomid and actually shut their HPTA down. So it's one of these things where you have to, you assess what the data is showing in terms of what the HPTA is producing following the drugs clear, and then understand, do I need to use PCT drugs in order to give this system a bit of a kickstart in order for my testosterone production to begin to pick up as normal?
So you basically see that if you introduce the PCT in the wrong time or the wrong dosage, you can actually shut down your own testosterone production by doing the PCT.
Yeah, and you will make things a lot worse. So you'll go through a period of, say, HCG, Clomid, if you follow the standard sort of PCT protocols, this is sort of where I completely agree with the power PCT compounds, but the application and times just needed to be changed.
Amazing.
If you go and do the power PCT when your HPTA is recovered, you know, you're introducing a synthetic mimic of LH, which stimulates your testicle to make testosterone. But that testosterone can also aromatize to estradiol. And most people don't realize, but elevated estradiol is actually what shuts the HPTA down. It's not an elevation in testosterone. The elevation in testosterone lets the hypothalamus sense doesn't need to produce gonadotropin releasing hormone. But it's elevated estradiol that's actually inhibitory to the hypothalamus. So when you have a high level of estradiol in your body, that's furthermore going to shut down the HPTA more so than the elevation in testosterone from what you've used. So that's why it's important even during a PCT protocol that you limit aromatization. And that's sort of where I put in that, you know, if you're going to use HCG, it's probably the only time when you want to use an aromatase inhibitor like exemestane or aromasin in order to preserve the testosterone that the HCG is making in your testicle so it doesn't get robbed to estradiol, which could feed back to the hypothalamus and keep the system shut down. So do you need a PCT? Most often than not, that patience and then assessing what's happened. Most bodybuilders will suffer to some extent with secondary hypogonadism. And secondary hypogonadism is where the pituitary just gets a little lazy and doesn't make enough LH and FSH. And that has a tandem effect then towards the testicle not making enough testosterone. In that instance, that's potentially where we might use Clomid in order to block or cause antagonism to the pituitary with this estrogen mimic. And what it basically does is tells the pituitary to amplify its luteinizing hormone production. So in other words, you double the amount of LH you're making, which in theory would double the amount of testosterone that your testicle will make. So that, you know, these drugs have specific purposes that you have to understand what the blood is saying first before implementing. Then I guess, do you always have to apply the same sort of methodology to your PCT? Well, you know, certain people, like I said, might need HCG if their testosterone production post-use is very low in order to stimulate that system again. But most often than not, it's still the same sort of scenario of monitor the blood and then implement a strategy that's going to be needed.
That's amazing. Right. I've got a whole bunch of questions about just PCT alone, but if you don't mind, we could move to the next one because this for weeks. So now we covered what is PCT, and the next question is what is TRT or HRT? So what is the difference, and what is TRT then?
Yeah, so I mean, like what we were sort of covering on the last one, if you are going to go back on again following your previous cycle, then like I said, it doesn't make sense for you to do PCT, run these drugs just because you're going back on in 6 weeks. So you have all these coaches going, okay, we're going to stop the cycle here. We're going to, you know, run HCG and Clomid for 4 weeks, and then we're going to go back on cycle again because we're going to help your fertility somehow. So you see all these protocols with, you know, guys that don't really understand what they're doing. My sort of philosophy was that if you are going to go back on again, now I wouldn't advise that you go back on after 6 weeks, because if you think about it, with the half-life of these compounds, if you're using enanthate, your blood plasma level will peak after about 7 weeks use, and then you're at a stable level of drug within your body. When you stop using, it takes about 5 weeks, again, the half-life elimination, for that level to fall. So when you finish your cycle, you've still got about 3/4 weeks where you have an elevated level of hormone to take advantage of. It's not that, you know, you finish your cycle and that's it. Oh, that's the end of my gains. And most guys, you know, guys don't ever apply this, you know, same sort of timeline strategy when they're planning in, you know, cruises, as to speak. they effectively realize that, you know, oh, I finished my cycle, so now all of a sudden I'm back to this low level when I have my drugs, whatever they're going to do in terms of their strategy. My view here is you'd be better served using TRT, which is testosterone replacement therapy, and mimic what your own body produces physiologically. So in other words, if your body produces 20 nanomolar of testosterone, then choose a dose of testosterone that will yield that same level, but it's being administered exogenously as opposed to your body producing it. So when you use testosterone as a performance enhancing drug, or for, you know, testosterone replacement therapy, it's bioidentical to what your body makes. So the only thing we've done is we've manipulated the hormone with an ester in order to sustain its release into the system. The reason for that is testosterone has a half-life of about 90 minutes in your body. So when your testicle makes it, it only survives in your body for about 6 hours at most, if you look at sort of how the half-life decreases. So in that sort of regard, that's why your body's constantly pulsing the fertility hormone in order to get the testicle making continuous amounts of testosterone. And that's sort of why you can't take testosterone as an oral tablet, because again, you'd be taking a tablet nearly every 2.5 hours in order to try and sustain your level. So when we synthetically modified the testosterone molecule with enanthate, cypionate, propionate, it was just to delay how the drug releases into the system. So again, the patient compliance of taking the drug is increased because they're either taking, you know, an injection every second day, every third day, every fourth day, and it makes things a little more bearable for someone who has to take this as a drug therapy as opposed to, you know, performance enhancing. Now, if you are going to go that route where you're going to go back on again, choosing to take TRT to mimic your own body's physiological production makes a lot more sense, because your body's health baseline will recover back to pretty much how it was had you done a PCT. So in other words, yielding a testosterone level of 20 nanomolar from an injection is the exact same as your testicle making it itself. The only difference is obviously that HPTA is going to be still shut down if you're using exogenous testosterone, which the main impact is going to be to your fertility. So your FSH and LH is going to be shut down. But if you can, I guess, accept that responsible risk that your fertility is going to be impacted, the health baseline you will regain, it will be the exact same had you come off and done PCT. All you're sort of mitigating here is when you do PCT or drug clearance, there can be a period of time whereby you will drop to almost a zero hormone production, which can bring on metabolic damage and metabolic dysfunction. So you might see the development of high levels of triglycerides in the blood, which can be damaging to the liver. Your blood glucose metabolism can be affected. So you have potentially a higher rate of adipose gain because of our liver is not making sufficient amounts of lipoprotein lipase. So all these sort of metabolic factors get skewed when you have no testosterone in your body. And that's sort of, again, another risk that comes with doing a PCT, because your body adapts to having a higher level of hormone. And this more so is more applicable probably to someone who's continuously using all the time and then decides to do PCT. They may actually run into more health issues with the PCT than using TRT. And that's sort of, again, another big risk that guys fail to understand, that if you manipulate your testosterone production for so long, your metabolic efficiency and your metabolism, obviously we sort of, I guess people might have a broad understanding that if you're intelligent with your nutrition and you're meticulous, you can increase your metabolic rate in terms of how much food you can eat for your body weight. And that's sort of a stepwise production over time, whereby you know, your maintenance calories might have been 3,000 calories at one point, and now you've slowly built it up to maybe be 3,500 or 3,600. So you're able to eat more calories but maintain your normal body weight, and that's again got to do with metabolic efficiency. That metabolic efficiency adapts to your hormone level as well, because of what testosterone does in your body towards helping with your glucose metabolism and helping with how you digest fats also. So when you go from this perfect testosterone level that your body's acclimatized to from years of use to basically what your body makes naturally, that metabolic efficiency drops and can actually start to bring in what we call metabolic syndrome. And that's sort of where guys don't actually understand that when they go to do PCT or they cease use of hormone following years of use, they've probably dug themselves into a little hole where they're probably going to be better off taking TRT for the rest of their life in order to bring their testosterone level more closely back to a higher physiological set point than where they were taking or making when they're natural. So with TRT, you're effectively trying to mimic what the body's making naturally, but administering it through an injection, a synthetic form of testosterone.
That's amazing. Well, you just you have touched on a subject, and I just want to explore that a little bit more. So let's talk about a fictional bodybuilder who happened to be 270, 37, and happened to be me. So I've been taking a 250 test for quite a while now. I'm talking about half year-ish plus. According to what Broderick says, I'm pretty sure you're familiar with the terms sports TRT. So basically, am I on sports TRT or am I doing a cycle?
In my opinion,
if I am, what's more important about what's the major factor about doing PCT? The length of the cycle or the strength of the cycle?
Right. So the second question, when it comes to PCT, it's neither. It's effectively what has happened to the testicle cells through to the exposure to the compounds. Certain compounds will cause higher rates of oxidative stress. So we know that the likes of the 19-nor testosterones like nandrolone and trenbolone cause elevated amounts of oxidative stress in the body when they bind to the androgen receptor inside our cells. If that binding occurs within our testicle cells, because again, we have to remember that androgen receptors are everywhere in the body. And probably we should have said to start, androgen receptors are the target for where these testosterone or anabolic steroid molecules bind to in your cells. If we have that docking to androgen receptors within our testicle cells, and they generate localized reactive oxygen species production, so we make these radicals. If you don't have a system of antioxidants in place to quench that reaction, you're going to irreversibly damage these cells in your testicle. That damage, your Leydig cells and Sertoli cells don't have stem cells. So when they get damaged, that's it. Those cells are irreversibly damaged. And that's sort of where you might see primary hypergonadism, whereby that Leydig cell gets completely damaged that it can't make testosterone anymore. So you effectively can't ever make testosterone. Or you might have damage to the Sertoli cells. So those germ cells that would mature into sperm are damaged irreversibly also. So when it comes to PCT, given someone like a success criteria of, is this PCT going to be successful or not? It's really got nothing to do with the time length you've been on, because I've done PCT guidance with pro bodybuilders who have wanted to retire and not use stuff anymore. But again, these guys who have been effectively been on for so long throughout their career have ultimately had to go back to TRT because of we start to see this metabolic syndrome start to play because of how efficient their body became with exposure to the compound. But we also have to understand then that perhaps the compounds that were used might have induced local inflammation and oxidative stress, but you can't predict you know, the level of damage that's gone on without potentially going and get, say, an ultrasound done on your testicle to see what damage has happened in the testicle. If you get an ultrasound done and we see deformity of the Leydig cells and the Sertoli cells, well, then we can sort of say, okay, this PCT might not go to plan. Or if it's in the goal of fertility, the sperm production may never, you know, it may never recover because of there's so many Sertoli cells that become dysfunctional. In terms of someone who's using 250 milligrams of testosterone, and how I view it is, let's say, for example, your natural testosterone production is 10 nanomolar before you ever went near testosterone. And 250 milligrams of testosterone, we know from the literature, yields a test level of about 45 nanomolar. So now you're per day. So now you're sitting at 4.5 times your natural production. So, you know, if we apply that logic for someone who's naturally at 30 nanomolar, does that mean then that they should be sitting at 120 nanomolar for an athletic TRT? Because again, it's the blood plasma level that we're interested in as opposed to the actual concentration of the drug. It's the drug plasma level that we're tracking in order to see an increase in, obviously, the desired effects. So to me, someone who's sitting at 45 nanomolar, unless their natural test was, say, 30 nanomolar, and you chose a TRT dose that saw them sit at 45, they're still sitting outside their physiological level of testosterone. Now, does that mean again, this is sort of then how complex this question gets, is does that increase their risk towards disease because they're sitting in that supraphysiological range? So again, it comes back to how much oxidative stress does testosterone create in the body? And we know, you know, I'm not going to say little, but a lot less compared to the synthetic anabolic steroids in terms of when they dock to the androgen receptor. So by having a elevated testosterone level, say of 45 when your normal level is 10, probably the biggest risk to you in that instance would be you'd have higher levels of hepatic lipase being suppressed. So hepatic lipase is the enzyme that your body uses to break down HDL. So when you have higher levels of testosterone, normally hepatic lipase in your body, the production of it would be suppressed. You now get an elevation in hepatic lipase. So your body's making more of this enzyme that breaks down HDL. So you're no longer producing higher volumes of HDL in your body. Now, that doesn't necessarily mean you're putting yourself at more cardiovascular disease risk. It just means that your body's capability to recycle lipids and cholesterol back to the liver is going to be hindered.
Is there anything I can do to combat this?
So I guess the main thing we should be trying to combat then would be LDL oxidation as opposed to HDL production. So when we sort of look at what sort of drives cardiovascular disease and atheroma and plaque formation, it's more than attributed to oxidized LDL particles as it is to an elevation in LDL or a decrease in HDL. So that oxidation of LDL, again, when we think about oxidative stress, if we have compounds in the body that are causing high rises in oxidative stress, we can be fairly certain then that it's causing oxidative stress to our LDL molecules that are in circulation of our blood. When that LDL becomes oxidized, it effectively becomes a foreign molecule to the body. So our immune system responds. Your white blood cells remove that oxidized LDL from the blood circulation and form what are called foam cells, which deposit then into plaque. If you can offset that LDL oxidation, as opposed to being, I guess, I'm not going to say having an obsession with raising your HDL, but we're having, trying to really focus the minutiae on, I need to get my HDL up, when really the main strategy should be to lower your LDL oxidation. Having adequate amounts of vitamin E, vitamin C, and polyphenols in your diet. These substances are what donate electrons to stabilize oxidized LDL back to a stable particle. So in other words, when an LDL particle becomes oxidized, if there's adequate levels of antioxidants in your blood, they come along and stabilize that LDL back to how it should be. So they almost sacrifice themselves in order to stabilize those cells in the body. That's sort of where, my whole foray into bodybuilding and formulating with the company Supplement Needs came from. Why I developed the CV stack, which is the heart stack, having a high level of antioxidants, polyphenols, substances that we know offset LDL oxidation in the literature. The 8 forms of vitamin E, like vitamin E exists in 8 forms: alpha, beta, gamma, and delta tocopherol and tocotrienol. So there's 8 forms of them. Most people, when they take a vitamin E supplement, they only take either alpha or gamma tocopherol, which will elevate vitamin E levels in the body technically, but they're not very good electron donors. It's the tocotrienols that donate their electrons as opposed to the tocopherols. So if you're using vitamin E as a supplement, I'd advise, look for something that has all 8 forms between the tocopherols and the tocotrienols. And that's one of the main trademarked ingredients that I put in the CV stack is Evnol, which is a trademarked form of vitamin E, which has all 8 forms of tocopherol and tocotrienol. That's sort of your sort of key master antioxidant when it comes to offsetting oxidative stress within your arteries. So by sort of sitting at that 45 nanomolar level, okay, main risk probably being that drop in HDL, potentially elevation of blood pressure that might cause a small bit of arterial damage that will probably feed more so into the kidneys than anything else. So we don't
I actually have genetically really low blood pressure. I'm sitting here at 270, probably 275. My blood pressure is not even 110 over 70, not even close. So that's thanks for God, that's not an issue.
Yeah, and I mean that's sort of where, when you sort of see this sort of I guess you have to view things in terms of what that athlete is willing to do. So whilst we have this sort of terms towards athletic TRT, which is sort of, dosed at 3 milligrams per kilogram, which, ideally someone who's sort of 100 kilograms is on 300 milligrams of tests. At your weight, you're at is probably significantly less sort of dosage in terms of milligram per kilogram. But how I sort of view it, like I said, is you go back to the serum level of testosterone, and that's what's more important. And that serum-free testosterone is what's more important, as opposed to a milligram dose based on your body weight. Because effectively, what you're really searching for here is not exactly to have a very high total testosterone number. You're looking for adequate free testosterone, which is the amount that is free to interact with your cells. And in a normal male, that only accounts for about 1 to 2% of your testosterone is actually free. The other 98% is either bound to sex hormone binding globulin or albumin. And what we try and do is we can try and manipulate our body's physiology to release more of this testosterone from the bound proteins to unbound or free, so that in theory we see an increase in performance, not because we've increased the total amount, but we've increased the amount that's free to interact with our cells. And that's sort of what we want when we take very high dosages. the artifact of using a very high dose is that you then end up with a very high free testosterone value as an artifact of, again, that percentage ratio that the more you take, the more that is going to be free, because again, it's still trying to balance the amount of albumin and SHBG you're making with the total level that's in your blood.
So basically you're saying that your dosage should be based on your blood work rather than on your body weight.
Yeah, I mean, well, when you think about it, that's what we're ultimately looking for, is that serum level of testosterone that's circulating in the blood. And why it probably makes sense that if you're not doing a cycle, yes, you're going to see a level of performance enhancement drop, but you're better off probably taking a level of testosterone that sees you sit in that physiological range. So it sees you sit at maybe 20 to 25 nanomolar. Again, if you apply this sort of logic to someone who has naturally a testosterone level of 8 nanomolar, when they sit at TRT of 25, they're already tripled their natural testosterone level. So you start to see how this gets very, very skewed. But why, again, someone who goes from an 8 nanomolar test level to 25 TRT can still suffer negative consequences towards their body's metabolism, because again, their body becomes more efficient at utilizing that testosterone level. And potentially, you know, their long-term use then of TRT, if they ever did come off, we could potentially see then that their metabolism will never recover to the point of where it was when they were sitting at 8 before they touched anything. So the blood plasma level, in my opinion, is what's more important. And I've had people try to argue this point to me when I've spoken about milligrams per kilogram, and effectively trying to tell me that, let's say your natural test level was 20 and you used your first cycle that sees you sort of sit at 300 milligrams. So your level sort of goes up to, say, 60. So you've now tripled your test level from 20 to 60. And I don't know, like, what these people were speaking about, but they're trying to tell me that they see, no increase in terms of performance or muscle mass gain when they've effectively tripled the amount of testosterone that's in their body.
That's what I've been saying. I only take 250, which is, after 22 years of working out, that's really nothing. And actually, I've never gone beyond that in 22 years. I gained 45 pounds in 6 months, only taking 250. So if someone says 250 does nothing, I don't know. I think your diet or your training sucks in that case. Because
exactly.
There's no way. It's no way.
And that's sort of where, with people who often, even consult with me on what their sort of first cycle should be. My opinion on the first cycle is you get your bloods done. You see what you're making naturally. You understand that where you sit now is an artifact of your natural test level, your training, your nutrition, and your recovery. If you sort of then take the testosterone part of the equation and you triple your testosterone level from your natural level, so say you sit at even 15, going from 15 to 45, which would be to take 250 testosterone per week, you should expect to see a triple in terms of your performance.
Correct. Yeah.
Because of you've tripled your test level, your training, so your recovery will increase, so you're able to train more frequently or train a higher intensity, and then your nutrition will increase because you're able to utilize more carbohydrates and oxidize more fat. So, anyone that tries to explain to me that, based on this sort of milligram per kilogram level, that, 3 milligrams per kilogram is sort of where we should be aiming to go with, it doesn't make sense, because again, for someone my weight now at the moment of 104 kilos, effectively athletic TRT of 3 milligrams per kilogram would see me sit at 300 milligrams. And right now, in terms of my own progressive off season, that's the dose I'm using. So, again, the PED dose is matching the TRT dose, which makes no sense. So, So it comes down to effectively, like I said, the plasma level and understanding, you know, where you sat naturally, where you're taking it to super physiologically with the dose you've chosen, and then everything else builds around that towards nutrition, training, and then obviously adequate recovery. But I just laugh when guys try to argue that 250 milligrams is, you know, is nothing in terms of dosages. And when you start working backwards towards in terms of nanomole levels, you then start to see this appreciation of, okay, well, I sat here, now I'm sitting at triple that level. And, you know, you could even get more complicated and really start throwing molecular chemistry in and start talking about the number of molecules in a given dose. And again, this is sort of a topic I covered on our education site, the SN Education platform. I'd done like a 10-minute talk just briefly breaking down, you know, the flaws of milligram per kilogram, because it basically assumes then that for each kilogram of body weight, there's a standardized number of androgen receptors. And as you linearly increase the amount of weight or body mass of someone, those androgen receptors increase linearly as well. But they don't. Because if they did, then you'd be able to design the most perfect cycle where you used just the right amount of compound to target, you know, that perfect amount of androgen receptors to give you that, you know, perfect ratio of performance versus risk. But we don't. And I mean, it sort of worked out at, I don't have it off the top of my head at the moment, but let me pull it up on my laptop here. I think I can. Is this going to go on YouTube?
Yes.
Right. So I'll we can share this slide just for some fun.
Actually, by the way, you just mentioned one thing, and before I get to my next question, are you still working for GP?
No. I left JP in 2019, so I'm full time. I'm the product manager for supplement needs, and then obviously I own SN Education. But effectively, I can share this on the screen now.
Yeah, I wanted to ask you about this SN Education later, but I'm just going to do it right now. So basically, you created this SN Education, and if someone wants to learn and know more about, you know, PED usage beside other things, so this is what you do basically. You do consultation. People can contact you, and if they really interested in using PEDs, let's just say that, you know, they're serious about competing and stuff like that, it's definitely worth it. It's definitely worth to contact you and learn about this.
Yeah, I mean, I'm open always for a 30-minute consult, and then SN Education is $7.99 a month. There's at least 16 videos released each month onto the website, and that ranges from nutrition to PEDs, health, training, rehab. Like Simon's one of the educators, so he does a lot of the rehab and training work. So you have access to a team, 7 people who are all basically, in my opinion, experts in their chosen fields. So I think, you know, for $7.99, it works out about £2 a week. We have a forum where you can ask whatever questions you want on the forum, and we're all on that daily to, you know, help share our knowledge. So it's definitely for what it's worth. I basically just got tired of seeing all misinformation, and I guess, like we sort of said about bro science, where we don't see any of this sort of being discussed on a logical term. So I'll share my screen here, and this is sort of from, so we should be able to we should be able to see it. So basically, you know, we can get very technical here, but there's a thing called Avogadro's constant, which means that for 1 mole of a substance, you have 6 by 10 to the 23 molecules. So in other words, that's 602 sextillion, like all those zeros. The molar mass of Anavar is 306 grams per mole. So if you take a standardized dose of Anavar being 50 milligrams, that contains 0.000163 moles. Now, if you work that out in terms of how many molecules, that means you have 98 quintillion 160 quadrillion molecules of anavar in your body. And then you can do it again for testosterone. The molar mass of testosterone is 288 grams per mole. 125 milligrams of testosterone then has 0.00043 moles, which works out at 260 quintillion molecules of testosterone. Now, like, when you start breaking this down in terms of milligrams per kilogram, this is where the argument just falls apart, because let's say the clinical dose study of anavar is 20 milligrams in 80 kilogram males. So in other words, that's 38 quintillion 900 quadrillion molecules of anavar. And again, if you break that down, that's an arbitrary dose of 0.25 milligrams per kilogram. So does that mean that you have 38 quintillion 900 quadrillion androgen receptor targets for effective dosing of an 80 kilo male? And if you effectively exponentially increase that for body weight, then that means that you need 25 milligrams for a 100 kilogram male, which again works out to 48 quintillion 550 quadrillion molecules. So now you can take the difference from the 100 kilo male to the 80 kilo male. So does that mean that you have 9 quintillion 650 quadrillion molecules being the difference between the two guys? And then that would make the assumption then that 1 kilogram of body mass has 482 quadrillion 500 trillion molecules, or androgen receptor targets. But we've
that's not the case, isn't it?
No, and we've never ever been able to standardize it. So when you see milligram per kilogram being effectively I guess educated on, you really start to see who has the background in chemistry and pharmacology. Nothing wrong with trying to estimate how much we should be using, but from a what we call pharmacodynamics perspective, which is how we study how these drugs interact with the receptor targets, milligram per kilogram dosing in terms of exponentially increasing dosage based on body surface area doesn't work. And there's very few compounds that we would prescribe that have this empirical dosing, is what we'd call it, based on body weight. More often than not, intravenous administered compounds would potentially be administered in terms of body weight, because of we have to view the body as a compartmental model. So we can't just understand that, the body is just one system. When you give an injection into the shoulder, it's not that the injection's in your shoulder and that's it. The body compartmentalizes, it absorbs that compound into the system and then distributes it throughout all the body to the relevant tissues. You might have a localized, interaction in terms of where you've administered that compound into your shoulder. The cells in that area might interact with the hormone first, but it slowly enters into systemic circulation in order to interact with the receptor targets. When you administer something intravenously, the compartmental model sort of becomes a little more skewed because you've gone directly into the blood circulation. So in other words, all tissues of the body are now being affected, as opposed to a compartmental model of an injection into the shoulder. So we might need to dose stuff we administer intravenously on a body surface area perspective, because again, we have to understand that when we administer something intravenously, it's interacting with all the tissue of the body pretty much instantly, and the renal clearance of how we clear it from the kidneys becomes a little higher than something that's being administered in terms of more locally. So we might need to be a little more careful that we administer the right dose based on the surface area for intravenous, rather than something that's taken orally or injected locally. So, I've got no issue with trying to be a lot more safer, but, my sort of take home point here is that, you have to be very careful on what's the selling point to trying to, almost like bro science, where we have this level of not secrecy, but they know secrets that we don't know. It's common science that, that was sort of where, when I was seeing stuff online and what I'd learned doing my, drug development and pharmacology degree, that eventually you sat down and thought, like, who honestly came up with these concepts? I mean, you then have to go back to, as much as I used to love reading all these books in my 20s, of say Dan Duchesne's Muscle Underground newsletters, where did he pull this like magic number of, once you go to 5 grams of total gear, that, things magically start happening? And, I've also, consulted with many top level pros that use not even a fifth of that. And, our top level competing bodybuilders, that that's sort of where you then get guys that try and call BS on the actual correct science, because they've listened for so long to what's sort of been educated beforehand without actually being shown the correct science behind it. Because again, after seeing that, number of molecules argument and receptor targets, your milligram per kilogram dosing sort of falls apart. And that's where it becomes probably more appropriate to look on it, the nanomole level, look at the plasma level and manipulating from there, as opposed to going by milligram per kilogram, because you could overshoot your plasma level based on your body weight, or you might actually underestimate it and be taking less for your body weight, and you might end up at a dose that basically you're sitting just outside that physiological range, when perhaps it might be best that you sort of lower that dose a touch and sit properly in that physiological range for a period of time before pushing back up again.
That's amazing. I'm only smiling and laughing here because I'm quite offended with a few PTs in the gym, and they all following you and they all know you. And before this interview, we had a chat, and they all said that you are at the level of smartness when you are scary smart. And I've never heard anyone being described as a scary smart, but now I know why. Right, Ian, next one. You just touched on this subject too. I'm sure you're familiar with the terms being hyper responsive for steroids. And some people can take a shot and gain 20 pounds. Some people need 5 shots to gain a few pounds. So what role the genetic plays in terms of PED usage and reacting to the PEDs? I know it's a really broad question, but if you can make it simple.
Well, this sort of comes back to, again, let's apply what I've been talking about in terms of the plasma level. So when you take a certain dose, let's say you take we'll stick with something simple like 250 test that yields a normal level of 45 in an average person. So again, let's say that person has natural test level of 15. So again, we're sitting at triple their test level. So we'd expect a good response. Now, let's look at what clears the compounds from the body, and that's our CYP enzymes in the liver. So we have these biotransforming enzymes in our liver that destroy and metabolize drugs so that we can excrete them in our urine or in our feces. Your CYP enzymes take on board these drugs, transform them into something different so that your body can no longer use it. So in other words, you might have testosterone enter the liver, and then it becomes oxidized or becomes reduced. It does all these sort of chemical transformations, so it's no longer testosterone. So by no longer being testosterone, it can't interact with androgen receptors, so it's become useless. So your body then removes it with excretion. What you'll find is certain people have CYP enzymes that are overexpressed, and you have certain people who have CYP enzymes that are underexpressed. So the overexpression may mean that they have too many of these enzymes. So in other words, they have a higher rate of metabolism of these drugs. So when they take a certain dose, it enters their system, but their system metabolizes and excretes it very quickly. So in other words, that would be almost like your slow responder. So they are a fast metabolizer of the compound.
That's amazing.
The reason why they'd be a slow responder would be because they're never achieving high levels of plasma testosterone because their liver is eliminating it quite rapidly. So again, for someone who's taken 250 milligrams of testosterone, we'd expect them to have maybe a level of 45. Let's say, for argument's sake, that person's only achieving a 20 nanomolar level of testosterone. All things assuming that they're taking real pharmaceutical testosterone and it's not underdosed. Therefore, that person who would normally sit at 15 has now moved to 20, and so they're not seeing any appreciable effect. So in that person, you would have to increase the dose in order to see a response. And that's where it becomes important that you'd be monitoring blood work to see where the plasma testosterone level goes to as you push the dose. Because again, if you gave them a milligram per kilogram dose, they could be, again, a fast metabolizer. So you're never hitting the stable level that they need to see a response. The reverse of this then would be, say you have a slow metabolizer or someone who has an underexpression of this enzyme in their liver. They could take, say, a dose of 250 tests and their total plasma level could be over 100. So what's happening there is the liver is slowly metabolizing the compound. So the compound is remaining in systemic circulation for a longer period of time. So whereby the normal person might only achieve a level of 45, this person now is yielding a level of over 100 because of how slowly the molecule is leaving their system. So that, I guess, underexpression of the enzyme or that slow metabolizer can get away with a lot less drugs than a normal person or a fast metabolizer. That's where we might see this person become a hyper responder, because in other words, that 250 tests now has their levels sitting at 100. So if their normal testosterone level, again going back to the 15 nanomolar example, they're now nearly 7 times their natural test level. The drug is staying in their system for a lot longer. So again, if they're following a cycle where they're continuously administering a dose over a period of time, when they reach week 6, their level could be 200. So again, you have to understand that it's again down to that individual's genetics and how these CYP metabolic enzymes are expressed on how they're going to respond to the compound. Then obviously the other side of the genetic response would be, again, their expression of androgen receptors within their body. So if they have a higher percentage of androgen receptors being expressed in myofibrillar tissue, so within their actual muscle tissue, as opposed to, let's say, sex organs or androgenic tissue like your skin, hair, nails, etc., well, then that person, again, is going to be a more favorable response, because the androgen receptor is going to dock into muscle androgen receptors and amplify, genetic expression in order to increase either muscle protein synthesis, elevate nitrogen retention, and limit muscle protein breakdown. So it comes down to, there's a myriad of factors here between the genetic response within the liver and how they metabolize and excrete the compound, and also how that compound is able to interact in the body. The other sort of scenario then as well would be their expression of aromatase genetically. So if they have higher levels of aromatase being expressed genetically, because again, aromatase is a CYP enzyme and it's expressed all throughout the body, so it has its own gene. If that gene is elevated in individuals, they're going to see higher levels of aromatase expression, which is going to cause higher levels of aromatization, which sees their testosterone level decrease in favor of producing estradiol. So again, you have someone who might not be able to get away with using a lot of aromatizing compound because it gets pushed to estradiol. And then you have levels of 5-alpha reductase being expressed in cells also, whereby testosterone, for example, is being reduced to dihydrotestosterone, DHT, which will have very favorable effects on strength and performance in terms of helping the nervous system acclimatize to heavier loads. But if that elevation in 5-alpha reductase is expressed in other cells of the body, like skin, hair, sex organs, prostate, you might see an increase in local sebum production. You might see an increase in inflammatory markers that again causes hair loss within the scalp. You might see an elevation in squalene oxidation, which effectively lets the acne bacteria proliferate and cause acne. So again, that comes down to genetics surrounding these other supporting enzymes in the body. So you have all these things that compound that, again, to go back to what I was sort of saying, when you do a first cycle approach, you should be looking at either doubling or tripling your natural testosterone level so you can understand your aromatization rate and your 5-alpha reduction rate also, to see what side effects manifest from doing that to your serum level of testosterone. Again, it also lets you see, again, let's say, for example, you're at 15 and the arbitrary dose was 45. By tripling your testosterone level, in theory, if you got your bloods done after 6 weeks of using 250 test and you seen it was either low or sky high, then it lets you understand, going into future cycles, how much do I actually need in order to see an appreciable result. And it comes down to, for the hyper responder or the slow metabolizer, that could actually make things a little more complicated for them, because again, true TRT for someone who is a slow metabolizer could end up being somewhere around 10 to 50 milligrams per week, would see their level fall at 20. And I've seen this personally with quite a bit of blood work where guys are slow metabolizers. I wouldn't say they're hyper responders in terms of the other aspects of their genetics, but they are definitely slow metabolizers whereby they need a lot less compound in their system.
So I might not have the genetics for in terms of structure and muscle length and shape and whatever, but I react to drugs very well because I never had to take more than 250. In fact, I actually competed at 220, 230 when I was 20 years old, and I've never taken more than 250, and I never ever taken any other compound. So that means that I actually react to drugs quite well. So in terms of that, I have good genetics. That's
yeah.
And actually, as you mentioned, side effects, I never ever had any side effects apart of the hair loss, which I lost it when I was like not even 30. But apart of that, never an acne, never any other issue. So that all comes down to enzymes.
Yeah, and how the body genetically expresses all these enzymes.
Right, cool. Side effects. You just mentioned that. I think there's a misunderstanding about what is the effect of steroids and what is the side effect of steroids. When people say that, glycogen retention, water retention is a side effect, which probably not the case. So basically, what is the effect of PEDs and what is the side effect of PEDs? What's the difference?
Okay, I guess you'd have to determine that an effect would be a positive benefit and a side effect would be something that brings maldetriment. So you'd be sort of trying to classify an effect of PED use would be increased rates of nitrogen retention and decreased rates of muscle protein breakdown. So in other words, you are increasing the rate at which you retain nitrogen that facilitates the building of muscle protein, and you're limiting the extent at which your body catabolizes or breaks down that muscle protein itself. So that's where you sort of see this anabolic effect. You may see a positive effect, like I sort of said with DHT, on your nervous system. So you're able to lift heavier and recover faster. So in other words, your frequency of training will increase, again, allowing you to progressively overload the musculature to force that adaptation to grow more protein. And I guess another effect would be, like you said, you have higher rates of glucose utilization and glucose oxidation. So your glycogen replenishment and retention rates within your muscle tissue increases, and your fatty acid oxidation within the liver increases also. So your utilization of fatty acids increases, so you maintain a higher level of leanness in the body. So it becomes a little more difficult in order to partition fatty acids into adipose. The side effects then would be probably something that we classify as bringing a negative connotation, or anything that's sort of negative, whereby, let's say, you have higher rates of potentially aromatization that increases estradiol. Estradiol would be a side effect, but it of itself brings its own side effects then, of potentially higher rates of water retention, or what we'd sort of consider mineral corticoid receptor activation. So not only do steroids interact with the androgen receptor, they interact with every steroid receptor in your body also, and they can cause negative or positive effects. So in other words, interacting with the mineral corticoid receptor increases your retention of minerals like sodium, potassium, calcium, magnesium, etc. And interaction with the glucocorticoid receptor blocks the effect of cortisol on that cell. So that's how you're limiting cortisol's muscle protein breakdown effect, is by the steroid molecule blocking that glucocorticoid receptor and stopping cortisol from breaking down that cell. So that would be all the sort of the effects, and where I sort of went on a tangent there, the side effects. If estradiol increases this mineral corticoid activation, then you're going to have higher levels of sodium, potassium in your blood. So your blood volume increases, meaning therefore you have a higher amount of fluid that your heart is having to move about the body, and that's where you see the rise in blood pressure. So
basically it's not all black and white, because if you think about that, let's just say aggression would be a side effect in case of, if my mom takes them, if my mom has to take steroids because she's, I don't know, kidney transplanted or something, then that's a side effect for her. But actually that's a positive effect for me, or for an MMA fighter. Same as water retention, that's a good positive effect to me, but maybe to someone in a hospital, that's probably not the case. So it's not all black and white, what is effect and what is side effect.
Yeah, exactly. And that's sort of, like I'm getting at that. It really comes down to what your definition of, I guess, a side effect, in my opinion, is something that is negative, and an effect is something that's positive. Even the likes of side effects, you can't really even say that a side effect of steroid use would be higher rates of aggression, because again, it goes back to that person's own personality and their own genetic expression of certain enzymes in the body that facilitate neurotransmitters. So if that person has a higher susceptibility to having raised serotonin, then they may become quite aggressive because of that elevation in serotonin. And the same scenario, that they may become a little more risky, or they might have a higher sex drive from the elevation in dopamine. So again, the elevation in dopamine production can be a positive effect, so you have a higher rate of libido, but it can be also a side effect, because post-use, that elevation in libido or dopamine metabolism can have a negative side effect, in that your libido then, when you drop your dose, becomes impacted because your brain is no longer receiving that same level of dopamine in it. So using the sort of term side effect and effect has to be very broadly termed towards what you consider, in my opinion, a positive effect and a negative effect.
Right. You just touched on another thing, the neuroscience, and I have 2 pages worth of question based on that only, but I think the time would be quite tight for that today. So I'm just going to skip that maybe to the next one. But all the question I asked today is basically for the viewers, for the Hungarian people. Now, the last question, because we reached nearly the 1.5 hours today. So the last question will be a treat to me, to myself. So this question is just for myself. I've got ADHD.
Yeah.
I'm sure you know that. All right. So, and I think it's, when it comes down to recovery, sleep is crucial. I'm having a really, really difficult time to fall asleep because I just cannot turn my brain off. And I've been taking supplements for that for over probably 2 decades, like, you know, the GABA, tryptophan, melatonin, stuff like that. When it comes to recovery and sleep aspect, if someone has a hard time to fall asleep and stay asleep, what supplements can I take to help that?
Right. Very, very broad question.
I know. So
I guess we have to understand that when we in ADHD, what's basically happening is there's an elevation in dopamine, and the brain is failing to clear dopamine at a reasonable extent. So the brain is very, very stimulated, and what sort of calms the brain into, I guess, a more inhibitory aspect is your GABAergic neurons. So that's why you'd use GABA as a supplement in order to help these neurons relax. So probably, you know, that's sort of where, when I developed the first supplement with supplement needs, was the sleep stack. That's
why I asked.
That was designed to offset some of the negatives that people's lifestyle can have towards their sleep. So in order to fall asleep, how we sort of understand the sleep mechanisms or the biochemistry is that we need a high level of serotonin within the brain to induce a level of calmness, and that helps to bring sleep onset on. So again, that's sort of where you become drowsy following a high carbohydrate meal because of that elevation in serotonin within the brain. But we also have to have an environment where dopamine is low, and dopamine, again, being a stimulatory neurotransmitter, is going to make things a little more difficult for someone to fall asleep because of the hyperactivity of the brain. The other issue is that our thoughts are almost compounding. So when you allow your brain to become hyperactive at night and you chase one thought to the next, that sort of then further amplifies the amount of dopamine that your brain is making, because you're chasing after one thought after the next. So you're never getting to the state where your mind is relaxed, and you're sort of fueling more dopamine going into the system. Pharmaceutically, sort of what they sort of prescribe here is the likes of barbiturates or diazepines, whereby basically it just docks into the GABA receptor and turns off your brain. Doesn't put you to sleep though. It just basically tells your brain switch off. Your subconscious and everything underneath is still processing information. So that's why your sleep quality, when you utilize these compounds, isn't very restorative, because you never enter into stage 4 sleep. So that sort of deep REM sleep. So with the sleep stack, you have 5-HTP, which elevates the serotonin, and that utilizes the P5P. So the phosphorylated form of vitamin B6 is P5P, pyridoxine 5-phosphate, and that converts your serotonin from 5-HTP.
What's the effective dosage of the 5-HTP, by the way?
So the 200 milligrams just mildly elevates your serotonin, because again, what you're trying to do here is just tip the balance towards a more, I guess, calmer neurotransmitter state in the brain. You're not trying to put in massive dosages, because again, you can cause upset to the balance of your neurochemistry by taking massive amounts of serotonin and dopamine donors. So with the 5-HTP, 200 milligrams tends to be a standardized dose for, you know, adults ranging from 75 to about 100 kilos. So it's not that you need to take more based on your body weight, because again, we can't really quantify how much transverses across the blood-brain barrier either. And that's sort of why we take P5P with the 5-HTP in order to convert that 5-hydroxytryptophan to serotonin within the brain. 5-hydroxytryptophan creating the serotonin is important because when you fall asleep, your body's own serotonin is what creates melatonin. So obviously we have what's called the suprachiasmatic nucleus in your brain. So it's behind your eyes. And when you take in sunlight, that's creating and generating melatonin. And that's sort of where we have the circadian rhythm from, where we're exposed to daylight during the day, and then darkness at night triggers the release of melatonin into your body to make you fall asleep. But that release of melatonin in the evening time is just to set you up for sleep. It's not to keep you asleep. And you won't have enough melatonin within that SCN of your brain to drive sleep all night. So that's why you're converting your own serotonin to melatonin is what keeps you asleep.
That's my issue. When I take melatonin only, I can take up to 10 milligrams and I fall asleep maybe in 20 minutes or half an hour, but 2 hours later I'm awake and done.
That comes back to the half-life. So melatonin's half-life, oral melatonin's half-life is about 90 minutes to 2 hours. So when you take, 10 milligrams, 2 hours later you're at 5, but your body makes 3 milligrams roughly, somewhere in around 1 to 3 milligrams by itself. So you end up in a scenario where the oral melatonin's metabolism is waning off and you don't have elevated levels in your brain. So your body wakes up. Your body's not melatonin is basically telling your brain while you're sleeping that it's nighttime. So you have to have adequate levels in order to stay asleep. The other instance is falling asleep. You have to have low levels of dopamine. So your brain is, again, calm with the serotonin, but it's not stimulated with the dopamine. And that's where the magnesium bisglycinate in the sleep stack was important, because magnesium supports COMT, and COMT is an enzyme that helps break down and metabolize dopamine, but it also has other, mechanisms of action in the body for estrogen. So COMT helps to metabolize estrogen as well. So as bodybuilders, probably one of the main minerals that we're deficient in is magnesium, because of the rate of, estradiol production, and also the rate of dopamine production, because you have to understand that androgens themselves drive dopamine production in the brain. So you have a scenario whereby with, again, in the form here of ADHD, where your brain's not able to break down dopamine at an appreciable extent while it's making it at a high amount. So supporting your brain's clearance of dopamine with a high level of magnesium bisglycinate, again, you're providing COMT with magnesium, which is what it needs to work. And the glycine in the bisglycinate, so bisglycinate just means 2 glycines. Glycine itself is a GABA inhibitor, so it blocks GABA. So again, it's helping to calm your brain down. And then the other aspect within the sleep stack is zinc monomethionine. So again, you need adequate levels of zinc in order to facilitate nervous system relaxation at nighttime. And the methionine feeds into methylation and SAMe production, and you need a small amount of SAMe before bedtime in order to methylate and remove neurotransmitters also. So when it comes to the scenario of ADHD, it's very difficult to quantify, exactly how much magnesium you need that person to take to keep up with COMT. And as well as that, there is a certain level of, sleep hygiene to it also, that being able to do a form of, say, cognitive behavioral therapy where you can not chase those thoughts either, because again, it's sort of a perpetual thing that when you start thinking of one thing, the next thought comes into your head, and the next and the next and the next. And that's
just before I go to the bed. That's the time, the 2 hours before bedtime. That's the time when I go through my emails, my online coaching. That's when I edit my videos. So that's probably not the best routine.
No, that's it. And that's why then you start forming these perpetual thoughts. And that's where, you know, sleep hygiene becomes quite important. But the other side of it then also in terms of with ADHD is that because there's such an elevation in dopamine, you start to see deficits towards adrenaline and noradrenaline, or epinephrine or norepinephrine, whatever way you want to call it. And that leads to this sort of, I guess, attention to task detail, whereby you don't have enough epinephrine or adrenaline in order to make you focus on the task at hand, because of there's so much dopamine in your brain stimulating thoughts in other directions. And that's where it becomes that's where they prescribe, you know, amphetamine based drugs for people with ADHD in order to block out that sort of pull of dopamine going off in one direction and keeping the brain sort of centered to task with that adrenaline aspect. So
you're basically talking stuff like Ritalin and medication like that.
Yeah, and dexamphetamine, all these sort of medications that they use. But again, it's to try and pull the brain back towards attention and focus through that adrenaline aspect, as opposed to dopamine. And again, dopamine feeds into norepinephrine and adrenaline also. But when you have such an amount being generated in the brain, you have then obviously, I guess it comes down to a rate limiting step whereby not enough of that dopamine is going down to adrenaline to keep you focused at task. So for sleep, definitely, obviously, the sleep hygiene is a big thing. And then it's playing with stuff like, I guess, magnesium bisglycinate, so you're supporting COMT to do its job naturally. We have to understand that when you have an elevated level of androgens, you're fueling that dopamine fire as well. And if you have a higher level of estradiol, you're again further putting demand on COMT, so it's never able to do its correct job with dopamine. And that was sort of why, like, the sleep stack was designed for people who suffered with insomnia, especially on prep, because of, you know, enhanced bodybuilders are using higher levels of androgens, especially like trenbolone, that has a higher affinity for the androgen receptor. Again, that slows down how COMT works. And if you have COMT that's working at a slower pace than what it should normally, you're going to see elevations in dopamine as well. So you're going to have an effect where you can't fall asleep because your brain is so overactive. And again, same scenario when someone's on a contest prep, they're either focusing on food, they're focusing on their hunger, they're focusing on, you know, the show date coming up, all these thoughts where they're not letting the brain even relax, compounded with that higher level of androgens, further, you know, makes things a little more difficult for sleep also.
That's what I realized when I'm on a diet, although I'm not competing, but when I'm on a diet, well, 4 hours at best per night. That's all I can sleep. I'm just awake, even more than normal. Right. Everything you say just brings up more questions, but we already reached the time limit. But Dean, if you don't mind, just one more question, because now we are at the subject of sleep. I know the target of the video is basically the Hungarian people, and we're both living in the UK, where things are a bit different from Hungary. So my next question will be probably a bit weird to Hungarian people, but I think it's quite common to you. What about THC when it comes to sleep and sleep quality? Does it work? How does it work? First of all, it's not illegal in the UK, just before someone makes a comment under the video. So what about THC when it comes to sleep quality and sleep quantity?
Yeah, so I mean, there has been a popularity towards using CBD oil or cannabidiol oil, and cannabidiol is a metabolite that's within cannabis, similar to THC's tetrahydrocannabidiol. So THC is the psychoactive form of cannabidiol. So when you take CBD, you're effectively utilizing the same sort of structured molecule as THC. It just doesn't have any of the psychoactive properties. So the CBD interacts with the CB receptors of your body, we're still sort of in the infancy of understanding exactly what CB receptors do to human physiology, but we do understand that it has certain aspects towards, I guess, switching the body into a more parasympathetic nervous system state and amplifying this sort of rest and digest pathways of the body. So when we utilize CBD, we're lowering total body inflammation. We're helping to induce, I guess, apoptosis within the body. So we're effectively resting and digesting the body's, I guess, cells. THC, when it comes to sleep, it can be a positive and it can be a negative for certain individuals. So for certain people, it will induce levels of drowsiness, which will see them have restorative sleep. For others, it may not go as well, and they may find that their sleep quality will significantly decrease, but their sleep quantity will increase. So their time of sleep will improve.
That's me. Yeah.
But their quality of sleep won't be anything significantly different. And again, that comes down to CBD and THC interacting with these CB receptors, but not really doing anything for the dopamine that's within your brain. So again, when we're sleeping, ideally, we want pretty much all aspects of the brain to be fully resting. So GABA is activated in the brain. Your brain is having a chance to properly, again, go through that rest and digest, where it's processing information from the day before, consolidating it into memories, and then obviously allowing some of this, I guess, cerebral fluids to be drained into the body, into the lymph. So again, you're clearing out what you sort of call toxins, and allowing your immune system within your brain in order to filter out byproducts. And again, that's sort of where we see potentially later on in life the development of Alzheimer's, because of how inefficient the brain's immune system has become at clearing away some of this plaque, and it's blocking the neuronal function of your brain. So when you utilize THC for sleep, it might make you drowsy, it might make you fall asleep, but the quality in terms of how your sleep cycles are progressing doesn't really significantly improve, pretty much to the same extent as if you had taken, a barbiturate or a diazepam, where you're just basically acting on one set of receptors in the brain, but completely ignoring the other aspect of neurochemistry, which is the progressing into the sleep phases. So your brain actually moving from alpha to beta to delta brain waves, because again, it's important that your brain works its way through these, I guess, electromagnetic cycles of where your brain's moving through different frequencies in the middle of the night in order to go through these restorative processes. And if you utilize these compounds, yes, you're getting a certain level of probably beta wave sleep, which is what you sort of see when you're in a very light sleep, but you're never entering into proper delta, which is deep slow wave sleep, where you then progress into REM in the earlier hours of the morning. Then, so it's very complex. You get into all sorts of neurochemistry. It comes back to even the models of how we treat insomnia aren't really, I guess, validated, because yes, we're making people have time in bed with their eyes closed, but we're never inducing this delta wave sleep, which is actually the restful deep sleep that you need.
Actually, you just mentioned the diazepam. I take diazepam about 2, maybe 3 times a week, and it just does what you just said, that I fall asleep, yes, but then 1 hour later I'm awake, and even if I stay asleep, I'm gonna have horrible nightmares. I'm awake every hour or every 2 hours. But what if I combine the diazepam with your sleep stack or with other sleeping aid product? So basically 5-HTP plus diazepam, because that's the thing I've never tried. So I either take supplements or diazepam, and I just cycle it basically. So what if I take the 2 at the same time? Would that help?
There won't be the only contraindication for the sleep stack with the 5-HTP is someone who takes an SSRI, so an antidepressant medication like a selective serotonin reuptake inhibitor, because
so you mean like Xanax? So for example, Xanax and sleeping aid, that's a no-go.
Yeah, I wouldn't anything that's sort of an SSRI that's going to selectively allow your brain to have more serotonin. The reason being is if you put 5-HTP into the system, it might just match what that person needs, or it might actually overshoot. And what that person ends up is what's called serotonin syndrome. And they wake up quite violent because of how serotonin affects aggression in your brain. So it's one of those ones that 5-HTP shouldn't be taken by anyone who's selectively increasing the amount of serotonin in their brain. But if they're using stuff like diazepines or barbiturates, where we're just acting on GABA, then there's no issue to helping with the sleep stack, because again, you're increasing the serotonin and then you're artificially, increasing your melatonin because of you're forcing that serotonin to melatonin. And that's where vitamin B5 is the key thing when it comes to converting your serotonin to melatonin. So that's why vitamin B5 is in the sleep stack, in order to convert the serotonin across to melatonin.
Right, Dean, that's amazing, and we nearly at 2 hours now, but I just can't stop smiling because this was, first of all, the most amazing 2 hours ever in my life, probably. And I just realized that when I thought I knew some stuff, I just realized that I know completely shit about PEDs and sleep and recovery. That's just amazing, and you are really scary smart. So I think that would do for today, because it's almost 2 hours already. By the way, I've got 5 pages question written down. I only ask you 5 questions out of the 50. But this was absolutely amazing, and thank you very much. Thank you so much for being on the show, and I really hope you're willing to come back for the second one, because we need to cover all these things. And thanks for everyone who watched this show. I know it's a bit more advanced level of education than the other podcast I do, but I think this is really important. And before you go, so if someone want to contact you, how can they find you? Where can they find you? And what service you can provide to people?
Yeah, so probably the best place to get me is Instagram. My Instagram handle is DietgainzSTM. Like we sort of touched earlier, I do run a consult service, or we have the SN Education website. If you want to, pick my brains, the forum is there every day. I'm there to answer questions. So like I said, we have the video content that comes out each month, the forum, and then obviously I'm the formulator for supplement needs. So we have our own website in the UK, or we have an EU distributor also, and that's sort of where you can get stacks. Sort of, we didn't even get to touch on supplements, so we have like supplements that are geared towards people who are taking performance enhancing drugs to sort of get to the root cause of trying to offset long-term disease. So the website is supplementneeds.co.uk, and I have a discount code, Dr. Dean, that will save everyone 10% off. So that's basically, I look forward to seeing everyone who follows on Instagram.
Cool. All right. So thank you very much. And thanks for everyone watching. Bye, guys.